Hello, everyone. So glad you could join us today. I am Joanna Sinwell. I am on the board of NAMI Johnson County, and this is our monthly Lunch and Learn. We have an exciting topic. I'm very happy to welcome Tara Mizrachi. She's here to share her expertise on the crucial topic of advanced directives for mental health. It's a subject she approaches not just with professional knowledge, but also with a deep personal understanding. She and her husband are dedicated advocates for her brother, who suffered a serious traumatic brain injury as a child. Their experience navigating the healthcare system has given her valuable insights into the importance of planning and advocacy. But in addition to her advocacy work, she's an author and creative force. As a military wife, she started Songs for Soldiers. She was a music volunteer for Mayo Clinic Hospice Program and the VA and has appeared on local radio and TV for her annual program on September 11th. Her music videos are posted on her YouTube page under Animations and Meditations, and her music is on all major music streaming services. Her book, Software for the Soul, Psalms for Everyone, can be streamed free on SoundCloud and is available on Amazon. Please join me in welcoming Tara Mizrachi.
Thank you so much, Joanna and Marion and Representative Miller-Meeks for being here, and as well as all our other esteemed guests. We appreciate so much. Basically, we're talking about advanced directives for mental health as part of a solution for delayed care. Basically, when we talk about the need for advanced directives, there is a great need for early intervention. Obviously, we can see in our city streets very often people that are homeless and their family members, their friends, their loved ones, they're people that there are sometimes even so many people have experienced this, and approximately 771,480 people in America are homeless, according to the U.S. Department of Housing and Urban Development as of January 2024. So we're talking about more than 771,000 Americans are homeless, and 2/3 of the people that are homeless are suffering from mental illness. This is according, there was a JAMA, a Journal of the American Medical Association, had a review study where they reviewed 85 studies and 48,400 participants in these studies, so very quite extensive. And they concluded that 2/3 of our homeless are mentally ill or having mental health challenges. And that's just when they just sample it one time across. But if you do it over a lifetime, that's 77%. So these are people that obviously, if you include their family, their loved ones, and all the people that are connected with these people, as well as just people with a heart, which is all of us, that's everybody. We're all affected by this. And what is this? There's a wonderful, wonderful programs that are right now in place, but we really need to do more. We need to really do more to address the problem. So I'm here as an advocate to put out one possible solution for part of the solution. Obviously, much more is needed. Basically, I guess, why is it needed here? When we're talking about more than 1 in 5 US adults are suffering from mental illness. That's 59.3 million people, 23%, more than 20% of the adult population. And we're having great mental health challenges in our younger people now with the advent of social media and all the pressures, with drugs now that are very, very strong and just do wreak havoc with people's mental health, affecting a lot of young people. I don't expect it to go down, the number. So we're talking about 23% of the adult population. Kids are having so many challenges. It's only, unfortunately, it's a big challenge. We need to take care of this challenge. And this is according to NAMI, the National Alliance that we're here right now with NAMI. Thank you. So what happens with mental illness? Not only increasing in time as far as the number of people, but when it is untreated, unlike physical illness, where we have treatments, it's very, very easy. You have a cold, you go to the doctor, they give you medicine. with mental illness, very often the symptoms are untreated and they deteriorate. And what happens when they deteriorate? Homelessness. Like we were just talking about, homelessness, 771,480 Americans, and that's considered an underestimate, are homeless. 2/3, like we said before, are suffering from mental illness. Then prison sentences. Well, what happens when people have untreated mental illness? They could possibly self-medicate with drugs, and they could make things worse, or they could need money to get the drugs, or they could be suffering from their illness and do a crime because they misunderstand things. Maybe they could assault somebody or rob somebody because of their illnesses, telling them that a person is a threat. They could, get involved with the wrong people, find themselves on the street, get involved with the sex industry and drug industry, all of these things. Suicide by cop. I mean, I think if a study was done, I haven't seen a study, but if one was done, they may find that a lot of the people that end up getting accidentally shot, perhaps they weren't paying attention to the police officer's instructions, perhaps because of mental illness. Of course, this is just me thinking about this idea, but it's certainly something to consider, that mental illness could certainly lead to accidental police shootings, drug overdoses, obviously, from depression, from all of a wide array of mental illnesses could cause that. And then we're talking about once people are in jail and what's happening. Once people land in jail for the reasons I discussed, 37% of the people that are in state and federal prison and 44% of people in local jails have a history of mental illness, but 3 in 5 are not receiving any treatment, and 50% that have medication, mental health medication, once they get in prison, 50%, no more medicine. So what happens? Would this happen if this was a physical illness? If somebody went in there and said, I have diabetes, I need my insulin, would 50% of the diabetics not get their insulin if they're in jail? Why is this happening? We need to do more. And then the other problem, obviously, is caregivers and loved ones and friends watching people that they know maybe have had mental health challenges in the past, and they see it happening all over again, and they're watching them deteriorate, and they're not allowed to help. Why? Because they're not yet a danger to themselves or others. So this is a problem. I don't know if this exactly is the solution, but it's definitely merits some thought. So here we are. This is one possible solution to a part of the solution for the delayed care. We all agree, I would think, that delayed care for mental health is a problem. One part of the solution perhaps is something called an Advance Directive for mental health, or called a Psychiatric Advance Directive. What is it? It's a one-page document signed by the patient, similar to other documents we could sign. There would be a psychiatrist perhaps that would be a part of the form, and saying the person at this time is well. The patient would write their wishes, that that these particular medications, this particular illness, this is what is their story. Perhaps they would appoint a mental health proxy, and then they would say, if I'm experiencing these symptoms, I would like people to know and to treat me. The document would be widely accepted. And right now the problem is people could sign all the documents they want, and the lawyer could say, oh yes, it's perfectly fine. But if the police don't know about it, if the doctors don't know about it, no one is going to be able to apply this to the person. So it would have to be something accepted, just like DNR, do not resuscitate, and medical proxy forms are today. And then police and medical professionals would have a shared database. So the person would have a QR code, much like somebody wears a bracelet for diabetes. There would be a little code. Police officer would go, what's up? Okay, we know this person has this illness, so let's treat them differently. And then the doctor, when they get into the emergency room, or into perhaps it would be better, into a mental health facility, they scan it. Okay, we have all the information we need. We don't have to figure it out again. What's the goal? Respecting patients' wishes, preventing tragedies. And it's a tightrope and it's a balance, but we have to find a way. So how much will it cost? Well, as we just discussed, it's a paper form, not much cost, a database shared by law enforcement and medical staff. So that would be the cost, I guess, would be this database, minimal cost. And then the barcode that I guess a person could buy, or they could have people, I'm sure charities would donate to have an ID, bracelets, magnets, keychains, etc. So now in real life, a woman suddenly collapses on the sidewalk in front of you. You shout, "Are you okay?" She's unresponsive. Her skin begins to turn blue. You shout, "Someone call 911." You check her pulse and her heart rate, her breathing, for respiration. You begin administering CPR. The paramedics arrive within a few minutes, place her in an ambulance, rush her to the hospital where she receives oxygen, medication, and care by a dedicated cardiac team. This is the way it works. After the patient's discharged home, she calls to thank you for giving her the help she needed. She says, if you had simply walked by and not helped her, the damage to her heart would have been much worse and her life may have been lost. You're thankful to God that you were able to help. Let us imagine the same situation, but this time it is not the heart, rather it is the brain that's not functioning. Same person, but different organ. And yet there is a world of difference in the perception of the person, the willingness to help, and whether or not the person receives medical care at all. This time, the woman has not collapsed from a heart attack, but she is just as unaware of her surroundings, not because her heart is malfunctioning, but because her brain is malfunctioning. She has false beliefs that she's being followed. She thinks that her thoughts are being monitored, and she's experiencing auditory hallucinations. She feels isolated. She's completely filled with fear, and she's walking the streets in this scenario. She's caught in a situation where she is clearly suffering and she's in need, yet no one is allowed to help her because she's not yet met the legal threshold of being, quote, a danger to oneself or others. You see this woman, and in an effort to help, you call 911. The dispatcher will likely tell you he can send EMS, but in all likelihood, there is nothing they will be able to do to help. There will be no paramedics rushing her to the nearest facility where she will receive medical treatment as quickly as possible. No ambulance, no hospital, no doctor. You're instructed to walk by, try to avoid eye contact, and keep going your way. Why the difference, you ask the emergency dispatcher. Similar to the woman who collapsed from a malfunctioning heart, this woman whose brain is not functioning well is not able to consent properly. Why are you not allowed to help her? The dispatcher will likely tell you that the reason access to mental health care is denied is based not on a medical definition. Rather, it is based on the legal definition of, quote, insanity as, quote, persons who are a danger to themselves or others. You must wait until she hurts herself or others or seriously threatens to do so before any medical person is allowed to help her without her consent, even though she's not able to give her consent due to her illness. But that's the law. What if you tell the 911 dispatcher that you're actually a relative, and before she was ill, the patient signed a healthcare proxy form appointing you to make decisions for her if she's not able to make decisions for herself? Since she's not aware now, just as if she was unconscious, you explain, you want her to receive care for her mental illness. The dispatcher will likely tell you that healthcare proxy forms apply only to physical health, such as being on a ventilator or in a coma. Even if a form specifies that it includes mental health, it would streamline the process, but there would still be need for a court hearing to decide if she is to receive the care she needs, and the current statute requiring patients to be a danger to themselves or others before they receive help would apply. So why? Why is this happening? Why are there such strong laws protecting mentally ill people? Well, there's really good reasons why. Just one thing to start out, in the Soviet Union, they used to take people that were political opponents or saying things that were perhaps against the government, and they would put them right into the mental hospital. So that was functioning as a way of discrediting the person and also imprisoning them. The history of mental health is full of fear of what we don't understand, because really there haven't been treatments that were effective until the 1960s. So even archaeology, in France, 120 skulls were discovered from 6500 BC, and 40 of them had holes in their head. And this was something that had been done they found in Greece, in Rome, in Peru, much archaeological evidence showing something called trephination, where there would be a hole in a person's head. And this came until the 1800s. And the idea was to release the evil spirits or supernatural causes that would cause the mental illness. 1600s to 1800s, bloodletting using leeches and venesection, ice baths. 1927 was insulin coma therapy. The death rate just from the therapy was up to 10%. And that went all the way up to the 1960s when antipsychotic meds became available. 1934, they started metrazole therapy, which they gave a medicine that induced very severe seizures. The FDA discontinued in 82, but the thought behind this was discovered in Hungary, the idea that perhaps seizures and psychosis were antagonistic. Also ended with medications in the 1960s, as we've probably all heard, 1936 to 1950s lobotomies, but the last one was in 67, also ended with antipsychotic medications. But today, things are much different. There are scientifically proven treatments that are effective, medications, antidepressants, antipsychotic medications, anti-anxiety, cognitive behavioral therapy, group therapy, electroconvulsive therapy that's very, very targeted, transcranial magnetic stimulation. There's even use of psychedelic therapy in conjunction with psychotherapy. All these have been proven effective, and more things are being discovered every day. But these are things that they're scientifically proven that help people, that people can live virtual normal lives in many cases once they get the medications right, without suffering, without being homeless, without being in prison. And we have the means to help the people. And the laws are saying they have to be a danger to themselves or others, which is very understandable. And also, in the middle, we have to be very careful. We don't want to be like the Soviet Union, which was just taking people off the street. Oh, here you go into a mental hospital. Obviously, we want to be very careful that this is not abused, and people are not treated against their will, without care and thought. But perhaps the pendulum that swung all the way towards the legal protections, which are really important, perhaps with a document where a person is signing it, perhaps that could go away towards bringing more treatment to more people, with obviously being very mindful not to violate people's rights, of course. So, like we just said, laws are designed to protect people's rights from being violated. However well intended, the legal system that seeks to protect people's rights breaks down when it comes to treatment of mental illness. People fall through the cracks as they are denied needed medical treatment, and sadly, the illness they need treatment for often causes them to be unable to request help. The very laws in place to avoid unnecessary imprisonment may result in imprisonment and suffering as people self-medicate with illicit drugs, harm themselves unintentionally, and injure others as a consequence of untreated mental illness. And people end up in jail, end up harming people because of the delay in care, and end up homeless and just suffering. If someone signs a form stating they want help, if in the future they are not well, it can be argued perhaps it is not against their will to give them aid. Advance directives for physical health can be extended to mental health so that needed medical care will not be denied simply because injury or illness is located in the brain. So is there a way to bring this intervention for those who have a history of serious mental illness? And that's really what we're talking about, really, is people who have a history. If they have substance abuse disorder, if they have schizophrenia, they have bipolar disorder, depression. If they're suffering with this illness and they're going up and down, sometimes they're feeling well and sometimes they go down. This perhaps may be a way to address this. Many of us, we go to the medical clinic, they hand us the forms, they say, would you like to sign healthcare proxy, do not resuscitate, HIPAA, all these forms we get. In case something in the future happens, we want to be prepared. They'll ask you, do you want to have a form that says, if you can't speak for yourself, do you want to be resuscitated? We gladly sign the forms in case something in the future happens. Just as there are advance directives for DNR, medical proxy, what if there was an advance directive for mental health that could be signed in the presence of a psychiatrist who confirms that the person's well at the time they are signing, and it will state that the person wishes to receive medical care if ever they exhibit certain symptoms. For example, if somebody has substance abuse disorder, if they go back on the illicit drugs, if somebody has schizophrenia or bipolar disorder, if they start exhibiting signs where they're having false thoughts or hearing voices, and they're saying in the future, I want to have care for this. It will state that the person wishes to receive care if they have these symptoms, and this avoids the terrible situation we're in right now, where we're not allowed to help people who are suffering from mental illness until they pose a clear danger. So we're sitting there watching people, and we know what's going to happen, and we have to wait. And this involves, like we said, millions of Americans. So it's a big problem. And sadly, often the help comes too late to avoid suffering or even loss of precious life. So Advance Directive for Mental Health, in this case, it would extend the existing framework for physical health to include psychiatric care while preserving the laws for involuntary commitment in case of immediate danger. These directives would grant first responders and doctors immediate access to a patient's diagnosis and pre-stated treatment wishes. For rapid access, a patient would carry a QR code, perhaps on their bracelet, and they would have a link directly to the care that they needed. So once EMS is activated, the police, paramedics, or mental health crisis team quickly responds. They scan the QR code, access the database containing the advance directive that the patient signed at the time that the patient was feeling well, and then contact information for the patient's doctors, contact information for the patient's loved one, medical proxy, and then the treatments and medications that have worked well in the past would be on that scan. He is not a danger to himself yet, but he wrote in his advance directive that even if he's not a danger to himself at this time, but he's exhibiting certain described symptoms that the patient expressed he wanted to get help at that time, the advance directive could go into effect, rather than wait until the symptoms deteriorate, as they've done in the past, and then wait for days in an emergency room until a bed is available at a psychiatric facility. The patient in this case would receive a home visit or an on-site visit, if the patient doesn't have a home, by a dedicated mental health team. And perhaps it could result in a direct admit straight to a psychiatric hospital or treatment at home, because it hasn't become a crisis yet. If this were an emergency, of course, the patient would be brought to an emergency room if the patient was a danger to himself or others. And then this would be, as we have the 12-hour hold in Iowa Code 229, that would go into effect. So the Advance Directive would not stop the process of helping people right now in an emergency. So same situation, now we revisit. You're walking the sidewalk, you see a woman in need of help, you call 911 or 988. Mental health team arrives within a few minutes. They quickly scan her QR code, which links to her confidentially encrypted advance directive that lists her diagnosis, her doctors, her medication, and a medical surrogate, who, according to her wishes, may give consent for her if she exhibits certain symptoms. Although, as a result of her illness, she does object to being treated. But as we said before, she did write that even if she says she doesn't want the treatment, she's writing that she would like to get it. Her medical surrogate does give consent on her behalf in accordance with her instructions on her advance directive. It turns out she has a history of severe brain injury, which causes her to have seizures and hallucinations. And on her advance directive, she wrote that she wants to receive mental health treatment and to be given medication to be treated by a mental health practitioner if she ever has these specific symptoms. The mental health professionals gently bring her to the hospital where she's promptly treated by a dedicated neurological and psychiatric team. So after she's discharged home, she calls to thank you for giving her the help she needed. She said if you simply walked by, her medical condition would have become much worse. And she's thankful that she signed the Advance Directive for mental health. It was easily accessible by all. The police were able to access it. The doctors were able to access it. And then she was able to be cared for before she was in a more deteriorated state. And then you were thankful to God that you were able to help her. So questions, I have some questions that are before we're going to open it up. There are some questions that we have some slides on. Does Iowa have an advance directive for mental health? So Iowa does not currently have an advance directive for mental health or a psychiatric advance directive, but it has a durable power of attorney. So in Iowa, this would be just a review of the history of in Iowa. Basically, from colonial times till the 1960s, civil commitment was too easy, and people with little concern for the civil or legal rights of people would basically just sign some forms, and it was a little too much that people were just basically put away. And the model for these reforms has been the criminal justice system, because reforms were needed. And it grants the accused a number of rights, including the right to notice of the proceeding and many rights like this. Under the statute, a person basically is, in those days, if the person was believed to be mentally ill and a fit subject for treatment, then they basically put people away. And that was not good. In 1975, reforms were made. And so as you can see, Iowa Code 229 was signed into law in 1975. So in Iowa, we have, according to 229.22, persons held in emergency department for up to 12 hours if a mental health professional determines that they are seriously mentally impaired and likely to be a danger to themselves or others. And that's where this advance directive would perhaps push the timeline back just a little bit and get the treatment before they're a danger. But this is in a situation that's obviously very real. When people are a danger themselves, the hold goes into effect for 12 hours, and the emergency medical professional communicates with the nearest available magistrate. The magistrate gives instructions, and then following the 12-hour hold, an application for involuntary hospitalization can be filed and a hearing was held. The challenges with this is that there's medicine and there's law. So the doctor is making legal decisions and the police officer is making medical decisions. With a psychiatric advance directive, the decisions are easier because the patient and the medical team that's taking care of the patient are all on that same page and putting that into a paper form that's accessible before the emergency. The other thing is that in medicine, it would be a non-emergency. And once we wait till the patient is a danger to themselves or others, very often they end up in the emergency department. Perhaps it would be better a person could have a home visit a little bit earlier. So which states accept advance directives for mental health or psychiatric advance directives? So these are the states. So is there a state that has recently done something a little bit different? So Oklahoma, in 2024, they provided a 30% increase in psychiatric residency positions. So they're trying to get more people to help others. A 7.8% increase for the Oklahoma Department of Mental Health and Substance Abuse Service. They streamlined the licensing certification for mental health workers, and they appropriated $25.7 million from the opioid lawsuit settlement fund to bring it to the Oklahoma Opioid Abatement Revolving Fund. Especially noteworthy is the bill 3451 of 2024 that updates the definition judges, law enforcement officers, and mental health professionals use to determine when someone may be held in protective custody. Previously, a person had to be deemed an immediate threat to themselves or others to meet the standard for involuntary hospitalization. So now in Oklahoma, officials can consider a person's mental health history over the past 72 hours, potentially making it easier for family members to get a loved one involuntarily committed to mental health treatment before deteriorating to become a danger to oneself or others. And this is a different approach. What are some other needs for mental health care that are not addressed by the Advance Directive? And as we said before, this is not the answer for everything. This would be really a select particular population, but it is something that is really needed and could be very helpful. So what is not addressed by the Advance Directive for mental health? Beds, 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 the three most important words. This is really, really what we need. Beds in hospitals for dual diagnosed physical and mental health care. We need this. Beds in psychiatric hospitals and clinics dedicated to mental health care. Right now, there's long wait times in urgent situations, very often becoming emergencies, while the person waits for a bed. Sometimes people are staying in the emergency room for long periods of time because no beds are available. So they're in an emergency room, and it doesn't really make sense. Beds for non-emergent, urgent situations, such as a patient wanting to change their medication due to severe side effects, they don't want to wait months for an appointment. Or a patient may need a bed to ride out a difficult time adjusting to increasing, getting off medication, or getting a new medication, because there's a time lag that it takes. As a result of a lack of beds, patients may choose to discontinue their medication on their own, resulting in avoidable deterioration. And this happens very often when somebody they need to change their medication. Perhaps they're having different symptoms, or the medications aren't working right, or they have COVID, a difficult crisis to deal with. The medications need to be adjusted. But if they're not in a safe setting under supervision, and they start getting the side effects, but they're not getting the benefits from the medication, they can just say, oh, forget this isn't working. And they don't have guidance from a medical team to help them. And then the spiral goes down, ending up in tragedy very often. Beds in group homes. This is so important. As an alternative to homelessness, supervised group homes provide supervision in a family-like environment. People could live in a place where it's so much cheaper for society, even though it sounds like it's expensive, but it is a wonderful use of resources to have somebody taking care of people in a home-like environment. Beds in juvenile psychiatric facilities. And very sadly, if minors, now we have more and more young people having mental health challenges, sadly, if they're in an emergency room, so we're waiting till the person is a danger to themselves or others, they land up in an emergency room, and because there's so few juvenile beds available, sadly, juveniles can be just staying in these emergency rooms for long periods of time, and they're suffering. And very often the family could be in another state, or the juvenile could be transferred to another state, so they're all by themselves. So when we say beds, obviously we also need staff, especially psychiatrists, who need to be hired in sufficient numbers to treat the patients in hospital emergency rooms, inpatient facilities, outpatient facilities, and clinics, homeless shelters, even prisons, very important. As advocates for advance directives, our hope is that visits will be at home or by appointment, thus preventing crisis treatment in the emergency room as a result of delayed care that results in deterioration and even tragedy that could be avoided. So special situations not easily solved with advance directives. What if a person, for example, is on methamphetamine or other drugs that mimic the symptoms of their illness? So the advance directive for mental health may not address every possible situation because for example, the diagnosis wouldn't treat exactly what's happening in this situation. So let's say they're facing a mental health challenge, but now a new thing has happened, like for example, the drug use. So there's a combination, but it'll still help because it'll still give the caretakers knowledge of at least part of their problem, even if the illicit drugs are now a new addition to the problems. So as we said, no advance directives do not address every situation. A mental health professional must still assess the patient. The goal is to provide for early intervention and allow police and medical staff to have easy access to the patient's diagnosis, including if there's a history of dual diagnosis or even part of the picture, but part of the picture is at least better than none of the picture. In the case of a drug-induced crisis or another emergency, Iowa Code 229.22 would be the guideline, and the patient would be detained for 12 hours and assessed by a court-appointed magistrate as to whether the patient will be released or detained. What if a patient changes his mind? I mean, that's a really good question. The patient, of course, may change their mind. In this situation, since it has to do with mental health, one would imagine that they may need to have a psychiatrist to certify that the person is at least comprehending their situation. But this is why we really need to discuss this, and perhaps we need to have national guidelines about this to make sure people's rights are preserved. So is an emergency department the most suitable place to treat mental illness, as is often the case today? We see from the picture, people are getting a heart attack, car accidents, all kinds of things. So emergency rooms are designed to handle emergencies. Patients are brought in often at the same time in severe pain and distress while suffering from heart attacks, strokes, motor vehicle accidents, other emergencies that need immediate treatment. If an advance directive for mental health could help a person gain access to mental health before the patient is a danger to himself or others, patient could be cared for in a setting more conducive to mental health, such as a home visit by a dedicated mental health team who could treat the patient on site or arrange even for direct admission to a psychiatric hospital. This way, the patient could be treated before the crisis. And there are no easy answers. But right now, today, the status quo is waiting, even though we know the person is in crisis. We make a decision. We're going to wait until the patient has deteriorated to the point at which they're a danger to himself or others. Treating patients in a non-emergency setting before a crisis occurs, it's better for patients, caregivers, hospitals, and society as a whole, because we have a safer, kinder community. So in summary, right now, very sadly, at least 23.1% of adults in the United States suffers from mental illness, according to NAMI 2022. And often this mental illness goes untreated. And when treatment finally occurs, it's often in the emergency department, under emergency conditions, or in prison, and in which case 50% of the people who go to prison with a prescription for mental health medication or treatment do not receive it while they're in prison. And today we're living in modern times when medication and treatment is available that can alleviate these very, very debilitating symptoms where people are suffering. Medical care should not be denied or delayed simply because the laws are not written to address the problem. There's a need for national law that will address the problem of untreated mental illness. And one part of the solution that is worthy of discussion, in my opinion, is a document that extends the legal protection of advance directives for physical health to also apply to mental health, so that there will be more clarity about what to do and who to contact in the event of a mental health crisis before the patient becomes a danger to himself or others, and before the crisis becomes an emergency. So QR code, scan, police officers, doctors, patients and caregivers, everyone, all the stakeholders can understand patients' wishes, the diagnosis, the medication and treatments that have worked in the past. Now, of course, the conditions may have changed. The doctors will evaluate, maybe not give the same medication. It's not like where you can order your medication just because you write it down. Obviously, the doctors will be evaluating very carefully which is the best medication, but it will be on there, accessible to the doctors. This medication has worked very well for this patient in this dosage and this time of day when they get it, or this therapy has helped the person. Perhaps it's they have now all different new therapies. Perhaps it's one of the newer therapies that is working for this person and may not be a very commonly used type of a treatment, but this patient, it helps. So, or another thing that could be on there would be the patient would say there's a group that the patient is involved in, a community group, or a place of worship, or something that has been helpful to the patient's care and therapy and recovery. And that could be on this document. And basically, it will not be an answer for every situation. There's still a need for more beds, quality facilities, psychiatrists, and mental health staff so the patients can be evaluated. We still need more beds. We still need more staff. This is so important, so that hopefully we can have people coming to people on site and prevent the situation we're in right now, and arrange for direct admission rather than delaying until the crisis and emergency, we can prevent people from being in the emergency room. Perhaps we can just bypass that altogether, have a dedicated team visit the person, and they have the requests that are known. There still needs to be the laws that we have today in the event of an emergency as currently exists today. We still need to have a discussion about whether commitment laws should be amended to adjust the requirement for being a danger to himself or others. But we have to be very careful. We don't want to go back to the way things were before 1975, where people were just put away, in the key thrown away without proper consideration for the person's rights. And one example, as we mentioned before, was Oklahoma, that's trying to strike that balance, saying deterioration of symptoms within the past 72 hours, rather than saying a danger to himself or others. So these are all things to think about. So the Advance Directive is for the person who's not a danger to himself yet, but has previously expressed wishes in writing for early intervention if ever his illness causes him to spiral downward, as he does not wish to deteriorate until he becomes a danger to himself. As a society, we should be able to honor such a wish as this. And basically, just in summary, we're really concluding the presentation. I think that was just the other two slides are just the summary of what we did. So we can open it up to questions. There it is. Thank you. Well, I do appreciate very much everyone coming, and I appreciate so much, especially our medical people here and our political people here, and the people that they're advocates that work so hard on behalf of our loved ones and our friends who are suffering so much. And I just appreciate so much everyone being here, and hopefully in the future we'll strike that proper balance between persons need to be treated and respecting their rights to not be just carried away, for no reason. We need maybe the pendulum perhaps has gone a little bit too much this way, so maybe bring it a little, or at least have these ideas like the Advance Directive for mental health. So I hope we consider this as something we can do to help those who are in need.
Right.
Tara, I think this is wonderful, and thank you so much for sharing this today. I'm the program coordinator at the Center for NAMI Johnson County, and we have people coming in on a daily basis looking for ways that they can take control of their mental health while they're working towards their wellness and recovery and trying to find stability. And I feel like this is so on that track of a way that they can have a voice, and they come to us because a lot of times what we also disregard is a lot of times the adults that we deal with, their support systems are the source of their trauma. And so a lot of times they're estranged from those individuals for a reason. And that leads them to feeling very isolated and alone, which is why drop-in centers like our place are so invaluable, because they find a sanctity, a family unit, a place to socialize, and they come and literally are having conversations. If I have a relapse, Amy, if I have a psychotic break, what do I need to do for you to help me and do this for me? And
Right.
those conversations are so challenging, you know what I mean? Because it has that question of where, as professionals, our responsibility begins and ends and what we can do. And a document like this could be so beneficial, where we could have that tool and say, this is what I can do to assist you and give you a voice and give you power over your health, your mental health, and to give you some peace of mind. Because just like Joanna said, paranoia and anxiety and all those things is so much a part of what this population deals with. So what we can do to give them that peace of mind can be invaluable. So thank you so much for the work you're doing, and your presentation was wonderful today.
Thank you so much. Thank you so much. And in the document could be listed the thoughts about things that the person is fearful of, or the thought that when I go to this drop-in center, it's helped me in the past. It could be on the document, so that so the doctor can look at it and say, oh, I better call the drop-in center. They're going to send a person that the person knows and they'll be comforted by. Or
Yeah.
the person feels paranoid. I don't want to be, this. Well, obviously, sometimes in an emergency, if the person's a danger to himself or others, we may not be able to be respected. But if the person's not a danger to themselves or others, and they're saying, I really want to go to the drop-in center, I really want to talk to my community, can you, could be, they could put that in there, and then we could assure them, I know you're feeling paranoid, or we wouldn't use the word paranoid, but I know you're worried about this. We're going to write that in the document. We'll include it in there. It's a document. It's 1 page, but they can write in what they want. Basically.
And we've even used opportunities with the center where we've been able to meet with DHS officers, legal aid, the DVIP, and other agencies. Have been wonderful to come in and meet with our people here, because it is one of the few, and for some of our people, the only place that is a safe place to them. So it really can be an invaluable support connector for people to get that mental health service that they need, so it's really amazing.
One problem that I see, though, is it needs to be accepted. That's why we need, so important, our legal officials, our like Representative Miller Meeks, who dropped in, and and the other and also Senator Grassley's staff member and Senator Ernst staff member. It's so important. This needs to be accepted. It's not just enough for somebody to write something on paper. The police, the medical people, there needs to be a shared database, like a QR code perhaps, or something like that, where quickly people can be accepting this document, just like the DNR and right now with the HIPAA forms we get. Everybody gives them a form. One more paper is not going to be a big deal. It needs to be accepted. I think that's the crucial thing. We could sit around and find papers all day long, but if nobody knows about it, it's not going to help anybody. It needs the lawyer, the politicians that are here need to pass the laws that say advance directives, mental health, psychiatric advance directives, that these are respected. Person's mental health wishes are respected and applied. That to me is crucial. Thank you for what you do too. Bless you guys.
Thanks everyone for joining us today. It was wonderful, Tara, to hear about such an important topic and to kind of get into the nitty gritty. I know that the barriers are large. Every state has their own thing, and just trying to get the legislature to understand the importance of this is the critical first step.
National guidelines, I think, would help too.
Guidelines, state guidelines, absolutely, absolutely. Thank you again for coming, and we appreciate your time today, and we certainly appreciate you, Tara. Thank you.